Ma'am, we are live, ma'am. I will start, ma'am. Hello, everyone. I am Dr. Elvis Himachalam Kutikopala, the State Convener of IMA JDN Andhra Pradesh. My warm greetings to IMA National President Dr. R.V. Ashokan sir, immediate past President Dr. Sharad Agarwal sir, HSG Dr. Anil Kumar Naik sir, IMA JDN National Chairman Abul Hassan sir, IMA AP State President Dr. J.C. Naidu sir, HSG AP Dr. Fanidar Polavarupu sir, IMA JDN AP Chairman Dr. Kiran Chetla sir. Indian Medical Association is the largest representing voluntary organization of doctors of modern medicine. Every year, there are about 50,000 fresh medical graduates joining the medical profession with already existing 9 lakh practicing doctors in our country. So there is a need to engage, unite, and stand for the young medical graduates. Hence, IMA has taken initiative to expand itself into a wing called IMA Junior Doctors Network, IMA JDN, where the junior doctors below 35 years of age are represented, supported, and backed up. IMA JDN Andhra Pradesh is one of the active state branches of IMA JDN in the lines to support and stand for the young junior doctors of Andhra Pradesh. Today, IMA JDN Andhra Pradesh is organizing this webinar to provoke knowledge and information to the resident doctors on multidisciplinary approach to diabetes mellitus and recent updates. I take this privilege to welcome Dr. Maithili ma'am, who is the invited guest speaker for this webinar on multidisciplinary approach to diabetes mellitus and recent updates. Dr. Maithili Aigari ma'am is currently working as a consultant endocrinologist at Visakhapatnam, Andhra Pradesh. She was the former professor of endocrinology at Andhra Medical College, Visakhapatnam. She was also the founder secretary at Diabetic Society, Visakhapatnam. She is the first lady endocrinologist of Andhra Pradesh. She has been involved in teaching undergraduate, postgraduate students in medicine and endocrinology for the last 30 years. It's a pleasure to have you here with us, ma'am. Now I would like to hand over the session to you, ma'am. Over to you, ma'am.
Thank you, Dr. Simhachalam. Thank you for all the kind words.
Yes, ma'am.
And thank you for inviting me.
Yes, ma'am.
And I sincerely appreciate IMA JDN Andhra Pradesh, Dr. Simhachalam and his team for the wonderful work, trying to educate young doctors on common topics like hypertension and diabetes. Today, we have such a huge population, we have huge numbers of people with diabetes and hypertension that whatever may be the specialization, any doctor should be able to do a basic workup and a basic management of diabetes and hypertension. So I really congratulate you for all the good work, and I sincerely wish you IMA JDN a very bright future.
Thank you.
Now, the topic Dr. Simhachalam asked me to speak on is multidisciplinary approach to type 2 diabetes and the recent updates. This is actually a wonderful topic. So why I really appreciate you once again for choosing this topic. So the topic is a multidisciplinary approach to type 2 diabetes. Now, why do we need a multidisciplinary approach to type 2 diabetes? What it means is just don't look at A1C, number, fasting, PP, and just don't leave there. You look at all the other, you need a holistic, multifaceted approach to the management. Then why we need a multidisciplinary approach is, I would tell you 3 reasons. So number one, 70% of morbidity and mortality of type 2 diabetes, even today, is cardiovascular disease. The second reason is type 2 diabetes is associated with several cardiovascular risk factors. I keep telling all patients, you have a diabetes, you are prone to have hypertension and then dyslipidemia because the root cause, the seed is the same, it is insulin resistance. So some people may have hypertension first, when followed by dysglycemia and dyslipidemia. Some people may have dysglycemia first, then hypertension and dyslipidemia. So finally, all three, they sit together these are the 3 important pillars for a cardiovascular disease. So it is important to address the cardiovascular risk factors. Number 3 today we realize that there are so many comorbidities associated with type 2 diabetes. Most important is obesity and NASH. We used to say NASH, now we say MASLD, that is metabolic dysfunction associated steatotic liver disease. So you have comorbidities, you have cardiovascular risk factors, you have cardiovascular disease. These are the three reasons that you need to have a multidisciplinary approach. What I'll do in my presentation today is, before talking about the management, what is important is for us to know briefly about the pathophysiology. Unless we know what is the pathophysiology of type 2 diabetes, the management is not understood easily. Then I will discuss the approach to management. So moving on to pathophysiology of type 2 diabetes. So what is this particular slide is a very old slide, 2009, you can see the reference. The slide shows that hyperglycemia worsens with type 2 diabetes duration. So on the x-axis, you have the time, and on the y-axis, you have the glucose. So what it shows, there is a derangement of the fasting is red, and then the postprandial is blue. So you can see there is a derangement of fasting plasma glucose. There is a derangement of postprandial glucose. And all this starts, the blue is before the onset of diabetes. The dashed line in blue is the onset of diabetes. Then you have the gray, which is progression of type 2 diabetes. So the derangements start even before the onset of diabetes. We all know that there is an average delay in diagnosis of type 2 diabetes by 5 to 7 years. That is, somebody could be having an impaired fasting glucose, an impaired glucose tolerance for an average of 5 years, even before the onset of diabetes. So 50% of your beta cell mass is destroyed by the time you diagnose somebody with diabetes. And what is again interesting is, of the two you see, both are increasing, but much more than the fasting, an earlier increase is in the postprandial glucose. So, however, you may see some individuals who have derangement of fasting more when compared to postprandial. Now, why is this so? So, I will explain you in the next slide. So you can say that the natural history of type 2 diabetes is a derangement of both fasting, derangement of postprandial, and there is a progressive increase in the fasting and postprandial glucose because of a progressive decline in the beta cell function. So the three important abnormalities which are responsible for hyperglycemia in type 2 diabetes are, number one is the insulin resistance. A resistance to the action of insulin in the peripheral tissues, particularly the muscle and the fat. Then, of course, there is a defective insulin secretion, particularly in response to glucose stimulus. This is the beta cell defect. And third is there is an increased glucose production by the liver. So you can see that the muscle and the fat, which have to take, the muscle has 70% of your glucose after you eat food, is taken up by the muscle. So most important organ is the muscle. So that is why in the management of type 2 diabetes, today we talk about muscle strengthening. You have a good muscle mass. The muscle takes more glucose. And that is how you can reduce your blood glucose levels. So a very important contributor to hyperglycemia is a resistance. When the muscle doesn't take up glucose, that is what is called insulin resistance. And that contributes to hyperglycemia. Now, what happens to the fat? In the fat, there is an increased lipolysis, which contributes to a decrease, again, an increase in the insulin resistance. So the second organ is the defect in the insulin resistance, insulin secretion, particularly in response to glucose stimulus. So we all know that this is the beta cell which is defective. It is not producing insulin. But then what is realized over the last decade is that secondary to a deficiency of insulin, insulin is the hormone which inhibits glucagon production. So secondary to insulin deficiency, there is no inhibition of glucagon production. So there is a hyperglucagonemia. This hyperglucagonemia is responsible for increase in the glycogenolysis and the gluconeogenesis by the liver, leading to increased glucose production by the liver. So these are the initial, but however, I will show you much more and more number of organs which are defective in type 2 diabetes. But the three cardinal abnormalities are the muscle, the fat, the alpha cell, and then the beta cell. Now, what is realized now over the last again decade is there are 10 organs. It is not simple what I have shown in the earlier slide. It is not just insulin resistance, beta cell, alpha cell. Now you have multiple complex pathophysiological abnormalities in type 2 diabetes. Look at the number of organs that are depicted here. So I will mention here at least 10 different causes for hyperglycemia. Now, let me begin with the pancreas. So, in the pancreas, there is a beta cell, a decrease in the pancreatic insulin secretion. And as I already mentioned, a decrease in the insulin leads to increase in the pancreatic glucagon secretion. So, there is an increased hepatic glucose production because of increase in the glucagon. And because of a decrease in the insulin, there is a decreased glucose uptake by the muscle. So, we finished two here. Then, if you see further, the most important defect in type 2 diabetes is the incretins. So, incretins are peptide hormones which are produced by the K and the L cells of the small intestine. So, these cells are responsible for whenever glucose is ingested orally, you find that the incretins are released and the incretins increase insulin secretion. Incretin, they increase insulin secretion. So there is a defect in the incretin production. There is a defect in the incretin action, which is responsible again for high decreased insulin secretion.
Are responsible for whenever glucose is ingested orally, you find that the incretins are released and the incretins increase insulin secretion. Incretin, they increase insulin secretion.
So there is an echo coming here, Simachal.
There is a defect in the incretin action, which is responsible.
Yeah, now it's clear. Then you look at the gut carbohydrate delivery and the absorption. So the people realize that there is what is called a gastric emptying time. People with diabetes may have a rapid gastric emptying time. There is a rapid carbohydrate delivery, which could be responsible for hyperglycemia. And then the most important organ, as I've already mentioned, is the liver, where there is an increase in the hepatic glucose production. Then people realize that the kidney is at fault. So they said, if you look at the kidney, one of the important functions of the kidney is to filter glucose and then reabsorb. So there is a tubular maximum for glucose. So in people with diabetes, you find that there is more and more glucose reabsorption from the kidney. So that is responsible for, there are receptors in the kidney called the sodium glucose transport receptors, and there is an increased reabsorption of glucose from the kidney, which is responsible for hyperglycemia. Then finally, the muscle, as again, I'm repeating that the most important organ which is responsible for glucose uptake in the postprandial state is the muscle. Secondary to insulin resistance, you may find that the muscle decreases the glucose uptake. And then the fat is responsible for the lipolysis. They increase the free fatty acid release from the fat is responsible for insulin resistance. So you can find the relation between the insulin resistance exerting its effects on the muscle. Now, what is the role of the brain? Today, it is what is called the decade of the brain in glucose homeostasis. So the various neurotransmitters from the brain have been implicated to be defective and responsible for hyperglycemia in diabetes. One such hormone that has been realized is the dopamine. So you find a defect in the dopamine function or the secretion, which could be responsible for hyperglycemia. However, we are not using such agents in the management. Now, why is it important to know all these particular, all these defects? Your anti-diabetic drug should be able to combat all these defects. Now, realize if we have a drug which does all these functions and reduces hyperglycemia, it is a wonderful and an ideal anti-diabetic drug. However, we do have, that is the reason why, because of the multiple complex pathophysiological abnormalities, if you look at the the pharmacological management of type 2 diabetes, we do give separate agents. We give metformin, we give a gliptin, we give a sulfonylureas, we give SGLT2 inhibitors. What is the rationale of giving multiple drugs? The rationale of giving multiple drugs is the multiple complex pathophysiological abnormalities. Now, a word about obesity and diabetes. Now, you can see this diagram. So, this is a lean individual where you find the pre-adipocytes and the size of the adipocytes. Now, what happens in obese individuals? You see the size of the adipocytes is increasing. What happens if the adipocyte size increases? So, an increase in the size of the adipocyte leads to inflammation of the adipocyte. So, this is what is called insulin resistance, which is obesity is the precursor for insulin resistance. One of the precursors for insulin resistance is obesity. And that is why you find the inflammation of the adipose tissue leads to release of so many cytokines. These are all the pro-inflammatory cytokines which are released from the adipose tissue in an obese individual. Now, what do these cytokines do? This is what is called insulin resistance. They inhibit insulin function. The most important function of insulin is promote glucose uptake by the muscle. So that is what is becoming defective because of the pro-inflammatory cytokines released from the inflammatory adipose tissue in an obese individual. Now, the other things that the pro-inflammatory cytokines the other aspects where they have been implicated are the endothelial dysfunction, cardiovascular complications, dyslipidemia, atherosclerosis, and then you find increase in CRP in obese individuals. The reason is an increase in it is because of the adipose tissue inflammation. So that is the relation. So this is the relation between dysglycemia and the cardiovascular risk factors. That is the reason why all of these exist together. Now, finally, what happens to the insulin secretion in diabetes and in a healthy individual? Now, this is the left diagram shows the insulin secretion in a healthy individual, and the right shows a type 2 diabetes. Look at this particular diagram. So the y-axis is the time, and then the x-axis, the y-axis is the plasma insulin secretion, and the x-axis is the time. Now, this is where oral glucose is, this is based on an IV GTT. Insulin glucose is given intravenously, and then the insulin that is secreted is plotted. So repeated samples for insulin were drawn, and what has been noted that in a healthy individual, when glucose is given intravenously, immediately you find an increase in the insulin secretion. So this is called the first phase insulin secretion. It's an acute phenomenon. It starts within minutes and it lasts for 10 minutes. Then what happens? There is a drop in the insulin secretion, but this is followed by a prolonged, a very slow second phase insulin secretion, which starts after 10 minutes and it lasts for almost 2 hours. See, very beautifully how the insulin is secreted in a healthy individual. What happens in diabetes? You can see there is no first phase here. Then glucose is given IV. Immediate glucose insulin secretion, which is happening in a healthy individual, is missing in type 2 diabetes. And then what happens? The second phase is blunted. So compared to a healthy individual, in type 2 diabetes, the first phase insulin secretion is lost and the second phase insulin secretion is impaired, leading to postprandial hyperglycemia, which is an earliest marker of type 2 diabetes. Now, finally, this is, I think, the last slide on pathophysiology. So you can see again here the different events that are taking place. So there is a fasting glucose, which is progressively increasing over time. And then the light blue is the postprandial glucose increase. And then the third is the hepatic glucose production, which is again progressively increasing over time. What are the 4 defects? Number 1 is a progressive increase in the insulin resistance. Number 2, you find a progressive decrease in the insulin secretion. Number 3, a progressive decrease in the beta cell function. Number 4, a progressive decrease in the incretin effect. So the insulin dysfunction, incretin, liver, and glucose. And these are the four important events that develop in type 2 diabetes, which are responsible for progression of type 2 diabetes and the development of microvascular and macrovascular complications. So why I have told you this pathophysiology is this paves the way. You know now what is the natural history of diabetes, and you know now what drugs to give, how the drugs, should be administered in the management. Now, something very interesting, what is new in the pathophysiology of type 2 diabetes? This is a concept which has been, the article has been published in 2018. When we say somebody has type 2 diabetes, this is a very heterogeneous group, a very garden variety. And then what these researchers have done is they said there are 5 subgroups, there are 5 different clusters of the so-called type 2 diabetes. So there are novel subgroups of adult onset diabetes and their association with outcomes. This is a data-driven cluster analysis of 6 variables. So the 6 important variables have been taken, and the so-called type 2 diabetes in adults have been classified as follows. So maybe the ADA and the WHO have still not accepted these definitions, but maybe the future you will not see a entity like type 2 diabetes. You would be seeing entities like a severe autoimmune diabetes, a severe insulin deficient diabetes, a severe insulin resistant diabetes, mild obesity related diabetes, mild age related diabetes, and so on. So when you are saying today type 2, what we are doing is we are just combining all these 5, and together, whatever may be the phenotype of the individual, we are simply dumping it as type 2 diabetes. Now, why is it important? What is the importance of these clusters? Again, the clusters paves way for the management. So somebody has severe autoimmune diabetes, you will find that these people need insulin only. They're insulin deficient. They have antibodies positive. And then somebody who has insulin deficient, again, you will find that they need only insulin. And the third cluster is an insulin resistance, where you would like to give an insulin sensitizers. These people are obese. They have increased risk of kidney disease. Mild obesity related diabetes is people are obese, and this is responsible for hyperglycemia. Mild age-related diabetes is 39%, again, older individuals. So if you see, most common are 4 and 5, what we are seeing. Sometimes we see young individuals lean coming with diabetes. So this is an autoimmune. Sometimes we see severe insulin resistance. They have acanthosis nigricans and they have diabetes. So these are all the different pathophysiological abnormal newer aspects of pathophysiology in type 2 diabetes. Now, with this, I will move on to approach to management. Now, when we say hyperglycemia, what do we mean? Do we mean A1C alone? Do we mean fasting? Do we mean postprandial? Today, when we talk about hyperglycemia, we talk of all the 3. That is, we need to address A1C, fasting glucose, postprandial glucose. And today we do have addition of glycemic variability and hypoglycemia. So this is what all the 5 together are called glycemic pendant. When you give an anti-diabetic drug, the drug should not produce hypoglycemia. The drug should address glycemic variability. It should reduce effectively A1C, fasting, and postprandial. So these are the 5 different aspects of glycemia that need to be addressed in the management of diabetes. And what is the importance of HbA1c? HbA1c even today is the most important marker of glycemic control, and it is an independent predictor of cardiovascular events. So my message is that all the 5 pented of parameters of glycemia need to be addressed in the management. What is our goal in the management of type 2 diabetes? Is it just to treat the glucose numbers? Again, it is important to treat all the glucose numbers, but in addition, we need to adequately address the pathophysiological mechanisms that are leading to complications. We do have many challenges in the management of type 2 diabetes. You can see that 88% of people are overweight or obese at type 2 diabetes diagnosis. Inadequate glycemic control remains a very important challenge even today. And then, as I have already mentioned, 70% of patients do have an increased cardiovascular burden. So the current practices in the management of type 2 diabetes are as follows. One is lifestyle modification remains the cornerstone. And then you move on to pharmacological management, not only drugs which lower glucose, but also manage the diabetes complications and comorbidities, especially the cardiovascular disease risk factors, hypertension and dyslipidemia. Then you need to give cardiorenal protection. That is, you need to decrease the burden of cardiovascular disease, decrease the burden of chronic kidney disease in people with diabetes. That is, when you really have, you are able to decrease these outcomes, that means we have really achieved the goals. Then address obesity, which is a very critical component of type 2 diabetes management. And then, of course, the MASLD, which was previously called NAFLD. A word about lifestyle therapy. So nutrition, very important aspect. The most important goals of nutrition are to maintain optimal weight. People need to know calorie restriction, especially in people who are obese. Then, of course, there are guidelines as to a high intake of polyunsaturated and monounsaturated fatty acids, plus avoiding trans fatty acids, limiting saturated fatty acids. And then, of course, you do have so many meal replacements and structured counseling today to address nutrition in type 2 diabetes. Physical activity, 150 minutes per week of moderate intensity physical activity, that is walking or stair climbing or strength training. As I've already mentioned, muscle strength training is a very important component. You can you can have a structured program. And today we have so many wearable technologies which are guiding people for a good physical activity. However, physical activity needs a medical evaluation, needs a medical supervision. If the person has a cardiovascular disease, if the person has a proliferative diabetic retinopathy or a severe disabling neuropathy. Very important component of lifestyle therapy is sleep. 6 to 8 hours per night of a good sleep hygiene is important. And then if there are sleep disturbances like an obstructive sleep apnea, a referral to a sleep study is important. Behavioral support, most important, you do have people who do need behavioral support because they don't want to take drugs, they do not want to take insulin, they don't want to behavioral problems as far as diet and physical activity is concerned. Smoking cessation, again, no tobacco products with if necessary, a structured program can be referred. Now, moving on to pharmacological approaches to glycemic management. Now, you can see here, again, I am back to my our diagram of pathophysiology. So we do have, today we have 11 drugs that are available in the management of type 2 diabetes. So we begin with the drugs which act at the level of the beta cell and the alpha cell are the sulfonylureas, which increase insulin secretion from the beta cell. Then we have drugs like the GLP-1 receptor agonists and the DPP-4 inhibitors. These drugs basically they decrease glucagon secretion. They increase the incretin effect. The incretins are released with the help of these drugs, and that is how they increase insulin secretion, and they also decrease the glucagon production. So this is again the same thing you can see at the level of the alpha cell. These drugs again are, they act at the level of the increase in the glucagon secretion by inhibiting the alpha cell. Drugs which act at the level of the increased hepatic glucose production are metformin. Most important drug which decreases the hepatic glucose production is metformin. Then, of course, indirectly, the GLP-1 receptor agonists and the pioglitazone, the thiazolidinediones, also decrease the hepatic glucose production. Now, the neurotransmitter dysfunction is yet to take off. But however, the GLP-1 receptor agonist, one of the non-glycemic mechanisms of action of these particular drugs, they decrease appetite. That is because of action at the level of the hypothalamus. Then I have already mentioned about the role of dopamine agonists. However, this was only at practically theoretical. Practically, we don't use these drugs. Now, at the level of the muscle, drugs which increase the muscle uptake of glucose are again the metformin, indirectly the GLP-1 receptor agonist and thiazolidinediones. So there is an increased glucose reabsorption at the level of the kidney. The SGLT2 inhibitors reduce the glucose absorption. And at the level of the adipose tissue, again, metformin, and most important is thiazolidinediones. They act at the level of the adipocyte and then they decrease the lipolysis. At the level of the GI tract, the GLP-1 receptor agonists and the DPP-4 inhibitors, they increase insulin, the decreased insulin effect is where these molecules act. So this is again, now how to use these also, we have so many agents. How do we use these agents? Previously, the concept was people used to start with diet, wait for 3 months, then they used to start with one drug, then they uptitrate, then again A1C goes up, add 2 drugs, add 3 drugs, finally give insulin. This was the olden way of treating type 2 diabetes, which is no longer valid when early combination therapy helps lowers A1C levels faster and provides a very good legacy effect. So what you do today, you do couple of, if the A1C is say more than 8.5, what we do is we start with 2 drugs right away. So an earlier and a more aggressive intervention provides more rapid glycemic control and therefore improves glycemic profiles without significantly increasing the incidence of side effects. So this is again, in a nutshell, how to select a drug. So this particular slide is available online. You can, if you go to the ADA guidelines, you will find how to select an anti-diabetic drug. So the first line therapy remains comprehensive lifestyle therapy. And in addition, metformin still we are giving first line. See, if somebody comes with, says, a fasting of 150 and then postprandial of 250, it is quite safe for you to just give him a metformin tablet because metformin is so cheap. It is so, doesn't have any hypoglycemia, doesn't produce weight gain, not much side effects other than GI side effects. So you're very comfortable drug to start with. And that is the reason why metformin has still been put at the first line. So that is a basic approach. Now, after that, what you do, how do you select the second drug? The second drug is chosen based on what is the comorbidity the patient is suffering. Now, if the patient has a coexisting atherosclerotic cardiovascular disease, the drugs like GLP-1 receptor agonist and an SGLT2 inhibitor with a proven cardiovascular benefit are usually the second line molecules after metformin and lifestyle therapy. Suppose the individual has heart failure or chronic kidney disease dominates. Again, the second drug after metformin is preferably an SGLT2 inhibitors, which reduces heart failure, which reduces CKD progression. And that is because there is so much evidence regarding the benefit of SGLT2 inhibitors in reducing the decline in EGFR, in improving the ejection fraction, people with heart failure or chronic kidney disease. This is a drug which is a wonderful molecule, which is usually chosen, and the drug decreases glucose, decreases sodium, decreases blood pressure, so many benefits, and that it a very important drug for cardiorenal protection. Now, somebody doesn't have all this, if they don't have any ASCVD or heart failure or chronic kidney disease. Now, you look at what he is. Suppose he is a politician, he is a professional who doesn't want hypoglycemia in his management. Do not give him sulfonylurea. Give him a DPP4 inhibitor. You can give a GLP-1 receptor agonist. You can give SGLT2 inhibitor or thiazolidine. Now, suppose you have a person whose main problem is obese individual. He wants to lose weight. Again, you can't give drugs which promote weight gain like sulfonylureas, or insulin. What you give is you give drugs like GLP-1 receptor agonists or SGLT2 inhibitors, which promote weight loss. So, 2 important molecules which promote weight loss in type 2 diabetes are the GLP-1 receptor agonists and the SGLT2 inhibitors. So this is how we choose the second drug. Now, after choosing the second drug, based on the goals, if the person doesn't reach an A1C of 7, this is how the flow chart. You keep adding this third drug, and then finally, patient may be using at least 3 or 4 anti-diabetic drugs, and if needed, insulin is started to achieve glycemic goals. Now, the recent updates in the management of type 2 diabetes are as follows, which I will show you. So, the cardiovascular risk management is of paramount importance. So, blood pressure management, hypertension, which is defined as systolic more than 130 and a diastolic of more than 180. Again, people with diabetes and hypertension qualify for antihypertensive drug therapy whenever the blood pressure is persistently elevated more than 130 by 80, and the goal is to keep it less than 130 by 80 millimeters of mercury. Lipid management. First thing, what you do see in diabetes is look whether the person has an ASCVD or he has a ASCVD or not. So if there is diabetes without any cardiovascular disease, you look at the number of risk factors this person has. If he doesn't have any target organ damage, that is no nephropathy, no retinopathy, and then if he doesn't have, if he has less than the ASCVD risk factors less than or equal to 1, the LDL goal is less than 70. Now, if the presence of there is a target organ damage and more than or equal to 2 ASCVD risk factors, the LDL goal is much more lower to less than 50 milligrams per deciliter. Diabetes with ASCVD, you can see the LDL goals are less than 50 and less than 30. These goals have been lowered in the last few years, taking into consideration the residual cardiovascular disease, even with an LDL of less than 100, less than 70. So, taking into consideration to further reduce the cardiovascular burden, the goals of LDL have been lowered in people with diabetes. What are the LDL lowering drugs? The drug of choice remains statins. We do add ezetimibe. We do add the bempedoic acid is one oral drug which is available. Then one of the injectables is the PCSK9 inhibitors, which is expensive and parenteral, which we do not use commonly. It is also after lowering the LDL, again, it is important to keep the triglycerides within goal. So the drugs which lower triglycerides are the fibrates, the saroglitazole, omega-3 fatty acids, and icosapentathine. So we talk about cardiorenal protection in people with diabetes. This is again in people with type 2 diabetes and chronic kidney disease or established heart failure. An SGLT2 inhibitor is proven to be beneficial. This will reduce the CKD progression and cardiovascular events. One important molecule which has come today, again an expensive molecule, is what is called finerenone. For people with type 2 diabetes and chronic kidney disease with albuminuria, and they are treated with maximum doses of RAS inhibitors and SGLT2 inhibitors. Addition of finerenone is recommended to improve cardiovascular outcomes and reduce the risk of chronic kidney disease progression. Obesity management, weight management is again very important because you may give drugs, some of the drugs like sulfonylureas and insulin, they promote weight gain. Now, an increase in the weight gain, as I've showed you how the adipocyte becomes increases in size and becomes an inflammatory molecule. So there is an increase in the pro-inflammatory state. There is an increase in the insulin resistance, and there is an increase in the cardiovascular events. So this is the reason why we need to have control. We need to have weight control for prevention of cardiovascular disease, and to decrease the number of anti-diabetic drugs. Also, you need to have a weight management and pursuing. This is an era where we are again facing the pandemic of obesity, and more so because of this, it is important to have weight management. So for individuals with diabetes and obesity, whatever, even a relatively small weight loss, even approximately 3 to 7% of weight loss, improves glycemia and other intermediate cardiovascular risk factors. I keep telling all my patients, lose at least 5 kgs, 7 kgs, 10 kgs, you will not need anti-diabetic drugs. That is the way you have to motivate them to reduce weight. Larger sustained weight losses, again, may have remission of diabetes. Today we talk about remission. People ask us, is this remission a reality? Yes, it is a reality. We don't call it reversal, but we say it is type 2 diabetes going into remission. Why remission is, it may be temporary. If people lose, suppose as a person who is 100 kgs, you tell him you go back to 80 kgs, you will not need your anti-diabetic drugs, you will go into remission. So that is the importance of the benefit of weight maintenance and weight control in type 2 diabetes. Finally, a word about metabolic dysfunction associated steatotic liver disease. This is the new nomenclature for NAFLD. The name has been changed to emphasize the importance of metabolic syndrome in people with steatotic liver disease. So this is usually the diagnosis is established by doing the fibrosis 4 index to assess the liver risk of liver fibrosis. So what do you give for these people? Again, lifestyle, promote weight loss. In addition, there are drugs like pioglitazone, saroglitazar, and some GLP-1 receptor agonists, which are effective to treat steatohepatitis. Last slide, recent updates in the management of type 2 diabetes is glycemic control matters. Even today, whatever may be so many comorbidities, A1C maintenance of 6.5 to 7 is of utmost important. It matters in the management of type 2 diabetes. We do have many treatment modalities and newer technologies which aid in the management. A very comprehensive medical evaluation and assessment of comorbidities is a multidisciplinary approach is the need of the hour, focusing on cardiorenal protection and optimal weight management. With this, the session is open for questions. Thank you, Dr. Simhaj.
Yes, ma'am. Ma'am, there are no questions as of now, ma'am. Ma'am, with your permission, can I conclude the session?
Yeah, please. Thank you.
Yes, ma'am. That was really an informative session, ma'am. You have covered various essential things on diabetes mellitus and the multidisciplinary approach to manage the condition, along with the recent updates. Thank you so much, ma'am. I would
Thank
also
you.
like to express my sincere thanks to the speaker, Dr. Maithili Aigari, ma'am, for sharing her expertise and insights on multidisciplinary approach to diabetes mellitus and recent updates, and its importance to the young generation and enlightening our young minds. Your presentation was not only informative but also thought-provoking, ma'am. I would also like to thank IMA and IMA JDN National for their support and guidance. My heartfelt gratitude to Dr. JC Naidu sir, State President IMA Andhra Pradesh, Dr. Fandar Polavarupu sir, HSG IMA AP, and Dr. Kiran Jitla sir, Chairman IMA JDN AP for their mentorship and guidance. We as IMA JDN Andhra Pradesh look forward to organizing more such events in the future and hope to continue this journey of learning and collaboration. Thank you once again for your support, ma'am.
Thank you.
Thank you everyone, and Jai Hind.